We'll talk today about sutureless aortic valve replacement as another alternative for the conventional aortic valve replacement. This is the anatomy of the aorta. Of course, ascending aorta, segment 0 and segment 1. We have to measure all each segment and each part of the segment because it would influence, as we will mention later in the slideshow. We have to measure the aortic annular diameter in per size, the sinutubular junction diameter, the heights between both of them. This will influence our choice for the valves, as we will say later on in the disease. As we know that aortic valve stenosis is the most common valve pathology in elderly patients, and the rapidly aging population is resulting in an increased number of people needing aortic valve replacement. Still, the aortic valve replacement is the gold standard for treatment of severe aortic valve stenosis with excellent short and long-term outcomes, and it also addresses the desire for less invasive approaches, quicker recovery cosmesis like mini sternotomies and right anterior thoracotomy. Today we're talking about the sutures or rapid deployment valves. We have 3 in the market that we've met here. The Medtronic 3F Enable, actually didn't use it in our hospital in the past 1.5 years. And the Sorin Percival and the Edwards Intuitive valves. Percival is a bovine pericardial aortic valve prosthesis capable to be fixed in place in a sutureless manner, and it's actually completely sutureless. It's truly sutureless without any suture. It's suitable to be implanted with any surgical approach, and this is how does it look. It has the calf down there, and the stent which has 2 parts. It's anchored from its upper part at the sinutubular junction over there, and this part that fits the sinuses. How to implant the Percival valve? It's as traditionally you will open an aortotomy, but in cases of Percival you have to go for high aortotomy because, as you've seen in the previous photo, there is a stent over there and it has to be accommodated with your aortotomy. So you have to go with a high aortotomy, which may make it a bit difficult to excise the valve. And you have to go at the fat fold, which is always present in almost all cases with the aorta. It's the landmark where to cut. Then you do decalcify and excise the valve as the routine way. You might need to suspend the valve with the commissures a bit, but during deployment of the valve, you have to remove this suspension. The third step is sizing, and sizing in the Percival valve is very important, not to use an undersized or oversized valve. It's very important. You have the sizer, and the sizer, it has a transparent end and a white end. The transparent one has to pass, and the white end should stand over there without force, should not pass. So this is the proper sizing. Then you put 3 guiding sutures, pass it either from the ventricular side to the aortic or vice versa. But anyways, the ventricular needle has to be put in the 3 hooks that we see over there, and then they will be removed. So it's totally sutureless valve. Then deploy the valve and inflate it with 4 atmosphere for 30 seconds. The indications for Percival, it's mainly in elderly patients requiring isolated aortic valve replacement. Although off record you can use it, of course, with concomitant with mitral valve replacement. But at high risk, due to associated comorbidities, it is important that the patient should be candidate for standard surgical intervention. It's indicated also in patients needing aortic valve replacement with concomitant CABG, in whom long times are expected to be determined in the presence of associated comorbidities. Preoperatively, measure the aortic annulus must be between 19 and 27, not less, not more. We cannot oversize, we cannot undersize here. You have to have the proper sizing for that. And of course, I'll leave Dr. Francois. He will give us the tips and tricks for that in the coming session. Relative contraindications also are active infective endocarditis or other systemic infections. Dilatation of the ascending aorta exceeding 4 centimeters in sinusoidal because it will not, the valve, as we said, it is anchored in 2 positions at the annulus and the sinotubular junction. So if there is dilatation in the ascending aorta, it will not be accommodated. The ratio between the sinotubular diameter and the aortic annular diameter has to be 1.3 if it's more than or less. If it's more than 1.3, so this is a contraindication for the Percival. In bicuspid aortic valve by type 0, and if the annular size is more than 27 or less than 19. The second valve is the Untitled, which is, well, actually, it is, we have to put 3 sutures, so we cannot say it's totally sutureless valve. You have to put 3 sutures and you have to tie them over. And the delivery system is almost very easy also with the Untitled, and it's a very good valve. And about the international expert consensus for both, we have to do pre-op CT and intraoperative TEE. And sutureless or rapid deployment valve should be considered as an alternative to the stented valves in patients who require the aortic valve replacement with biological valve, especially if the patient requires a redo or has a delicate aortic wall condition. Sutureless valves should be the first choice for valve prosthesis for patients who require concomitant procedures or small aortic root annulus, because they give a very low gradient. Oversizing with the sutures valves should not be done. Suitable annular size is between 19 and 27, as we said before. Complete decalcification of the aortic root has to be performed carefully, and if there is any injury, has to be repaired before implantation of the sutureless valve. Type 0 bicuspid valves is a relative contraindication. And of course, this reduces the cardiopulmonary bypass type, aortic cross clamp, and leads to less early complication. It also decreases ICU and hospital length of stay. In our Princeton Cardiac Center experience between June 17 and October 18, we performed 18 cases of rapid deployment aortic valve. 12 of them were Percival and 6 of Untitled. Average age in both groups are around 65. 75 of them were males in the Percival, 100% in the Untitled. Only 1 concomitant CABG with the Percival. We used the Percival. 80% were operated with full sternotomy and 20 by mini sternotomy. Cardiopulmonary bypass and aortic cross clamp time were comparable between both groups. We didn't have, fortunately, we didn't have any perivalvular leak or pacemaker implantation, although it's reported it's around 5% in the literature, but we didn't have any. And the mean gradient post-op was around 10. And the effective orifice area was around 2 without any stroke cases. There were no significant difference in the perioperative course and morbidities between the 2 matched groups. The mean hospital length of stay was similar, around 6 days with 0 mortality. We only had 1 patient of the Untitled group had EF, and it was resolved, another with right pleural tapping. There is no international recommendation for the use of specific sutureless valve. However, the Edwards Untitled valve, you will go for low aortotomy, which will ease your excision and decalcification of the valve. In the Percival, you have to go high. It's a bit more difficult, and if you need the long aorta for whatever more proximal anastomosis, I think it might be a bit of a difficulty. Now let's review the literature and what they said about the rapid deployment. There was a direct comparison between the Untitled and the Percival in the annals in 2018. And it was all comparable, and the rate of pacemaker implantation was also comparable, ranging here between 18 to 13%, no major difference. Here also between the Intuity and the Percival the comparison, it is the same, and it shows shorter bypass and cross clamp time in the Percival group, which was not significant. This is not important. And also in another, it was in another paper in the Annals of 2018, comparing Edwards and Percival. It showed also they both are almost comparable with no difference between both of them. Now, in the literature, they started to talk about the rapid deployment versus conventional. Versus the conventional bioprosthetic valve replacement. The incidence of pacemaker implantation and disabling stroke was found to be higher in the rapid deployment, whereas no beneficial effect on the hospital mortality was seen. Sutureless Percival aortic valve replacement also with the bioprosthetic showed its better hospital stay. And in another study done also 2018, talking about the sutureless aortic valve whether it's superior to TAVI or not, in this study the incidence of leakage around the new valve was higher in the TAVI group, which is important, versus the surgical sutureless valve group. And it's really significantly different between around 33% in the TAVI group and 4% in the rapid deployment valve. And the survival in the TAVI group was lower, 84% versus 97% for this. In conclusion, rapid deployment valves reduces aortic cross-clamp and cardiopulmonary bypass time. They're designed to deliver comparable hemodynamic results as stentless valve. We're starting also a program using these valves for minimally invasive aortic valve replacement, mini sternotomies, and right anterior mini thoracotomy. And the international experts recommend sutureless aortic valve replacement together with minimally invasive approach for eligible patients requiring biological valve replacement. Long-term follow-up is necessary to evaluate the longevity of the valves. And the message that we have to have that rapid deployment aortic bioprosthesis may provide an improved safety and efficacy profile compared with conventional surgical aortic bioprosthesis and transcatheter aortic valves. Thank you. Thank you.